guest to the 12th parallel session of the 11th National Summit of Health and Population Scientists in Nepal. Today's session, Essential Medicine and Pharmaceutical Products, will delve into critical themes such as medical utilization patterns, ethical research frameworks, drug-related challenges, treatment practices in Nepal. With one invited talk and 4 research presentations, this dialogue promises to unlock transformative insights for the Nepal's healthcare landscape. To guide today's discourse, we are truly honored to have 2 distinguished experts joining us as the chairs of the session, Mr. Narayan Dhakal and Mr. Prajwal Jang Pandey. Ladies and gentlemen, please allow me to introduce Mr. Narayan Dhakal. Mr. Dhakal is the Director General of Department of Drug Administration. With over 30 years of experience in regulatory affairs, Mr. Dhakal has played a pivotal role in the regulation of pharmaceuticals and ensuring the quality assurance of medical products in the country. Under his leadership, Nepal has developed and implemented various national medicine regulatory frameworks, pharmaceutical policies, and guidelines related to medicine. Mr. Dhakal remained steadfast in his commitment to strengthening the health and pharmaceutical sectors, with a focus on enhancing pharmaceutical management systems, advancing research and development, and improving pharmacy care and services. His efforts are closely aligned with the vision and mission outlined in Nepal's National Health Policy, Drug Policy, and Nepal's health sector strategy. These initiatives are geared towards improving basic health services in the country, all within the broader context of universal health coverage commitments. May I request Mr. Dhakal to be in the dais. Thank you, sir. Likewise, introducing Mr. Prajwal Jang Pandey. He is a distinguished industry entrepreneur, diplomat, and leader in the pharmaceutical industry. He served as the chairman of the Nepal Pharmacy Council and the executive director of pharmaceutics at Lomas Group of Industries. His leadership has been instrumental in regulating and promoting the pharmaceutical sector in Nepal, ensuring the availability of high-quality medicine. In addition to his business achievement, Mr. Pandey holds the position of Honorary Consul of Rwanda to Nepal, where he works to strengthen diplomatic and economic relations between 2 countries. He is also actively involved in the international youth leadership initiatives, having contributed to the UK Prime Minister Rishi Sunak's campaign. May I request Mr. Prajwal Jang Pandey to take your seat on the dais. Thank you, sir. Respected chairs, the floor is now yours, and we look forward to your guidance in navigating the key presentations and discussions that lie ahead. Thank you.
Okay, thank you. Thank you for very nice words and introduction. We are very pleased to be in this very important session. Am I audible? Very good. So, as she has already outlined, we have several presentations. So, we'll have a presentation followed by discussion. So, on this aspects, I would like to request to introduce Dr. Mary Watt. She is a pediatrician with a specialty adolescent health training, a researcher, and a pediatric ethicist. She is a professor of pediatrics and global health at the Ikahan School of Medicine at Mount Sinai in Newark, USA. Her theoretical and empiric work in ethics focuses on the ethics of research and with children and adolescents, including capacity and consent. So may I request her to carry her, presentation. Please, floor is yours. Yeah, please.
Yeah, I'd like to thank the conference organizers and our distinguished chairs for this opportunity. I'm really thrilled to be here. I'm going to talk on a research regulation topic that's highly relevant to medicines and pharmaceuticals, and this is the inclusion of children in research. Oops, I do have a disclosure. And I have two pieces to this talk. On a theoretical aspect, I'm going to use a theoretical framework to assess the vulnerability and appropriate access to research for children. And then I'd also like to talk about applying empiric data on child decision-making capacity to consent, assent, and permission. So this is a picture of the Nepal population pyramid. This is why research with children is really critical. We've got a large demographic bubble coming up and through. A third to a half of the Nepali population is under 20. Additionally, 40% of drugs that we use in children are used off-label, meaning that the indication has not been studied in children. So it makes child inclusion of research a really critical issue and an issue of health equity. So I want to talk first about theory. And one piece of addressing health equity is really to rethink inclusion of children in research. And this comes from the last updates of CHIOMS and the Declaration of Helsinki, where they emphasize that exclusion is not protection with children, and they feel that children and adolescents must be included in health-related research unless a good scientific reason justifies their exclusion. So it's a real switch for those of us who've worked with children. We're justifying, we have to justify exclusion rather than justify inclusion. And this is due to a change in a theoretical paradigm. So we're going from group membership and group membership, so this is a child, this is a pregnant person, to the individual characteristics and context of that child's life that make them vulnerable. So is this child dependent on others? Are they in extreme poverty? Do they have decision-making capacity? Do they have a medical illness that would impair their ability to consider? And it's important with children because children are developmental moving targets. So this is a hard to see picture, but you have a 5-year-old at the front holding the teacher's hand and a 14-year-old walking behind the teacher. The vulnerabilities and the needs in research for that 5-year-old are markedly different than those for the 14-year-old when you think about capacity, when you just think about the biology of the child's body. So we really need to take this thinking about what are the characteristics of the child, the age, and what are the social contexts in which they live. And so equitable access, or appropriate access, as my European medicine colleagues call it, is when you identify specific vulnerabilities of the child, you design your research to support those vulnerabilities, and you have and access is equitable. So my second objective is to talk about empiric data and how that can inform our approach to consent, assent, and permission. So CHIOMS and the NHRC require parental or guardian permission prior to doing research with children, as well as adolescent assent or agreement of the child consistent with their developmental capacity and maturity. The information needs to be tailored to where the child's at. Assent is a child's affirmative agreement to research procedures, and the NHRC policies on consent really reflect this developmental difference across childhood. Decision-making capacity is really important, something I've been focused on in my career. It's the capacity or the ability to appreciate the risks and benefits of a clinical situation or research and make a reasoned choice. And the elements include understanding the research, appreciating how it would affect the child themselves, reasoning among different options, and making a voluntary choice. This evolves across childhood and adulthood. So there's been 2 decades of research on the adolescent brain and decision making that can inform how we think about this. There was a Dutch study in a children's hospital where they took children signing up for clinical protocols and did a standardized capacity assessment on them. The children were 6 to 18 years of age, and they found that kids had adult type or adequate capacity to consent by 11 to 12 years of age, so really by the end of early adolescence. My own work has focused on capacity to consent for teenagers, and this is a study looking at kids' capacity to consent after a simulated consent process with a headache medicine. We used the MacArthur Competency Assessment Tool for clinical research. We looked at understanding, appreciation, reasoning, and choice. The second column shows the range of scores that were possible. The third column shows where our children in our study scored. We used 12 to 21, an American definition of childhood. And the kids in our study scored at the upper end. The last column shows studies using this tool from healthy adults and where the healthy adults scored. And you see that children in our study scored in the same range as healthy adults. Going back to the developmental part, though, I was really interested in how this capacity evolved across adolescence and whether there were any modifiable risk factors that we could use. And what you see is that middle adolescents, 15 to 17, had the same capacity as older adolescents who were legal adults. Younger adolescents who were 12 to 14 had lower capacity. Also of note was health literacy was associated with increased capacity, so it gives us a way to intervene. So you think this is from, my data is from a very high resource setting, but these data have been replicated in low resource settings. Working with a set of colleagues in Rakai, Uganda, we looked at capacity to assent to HIV research. The capacity scores are on the left-hand side, age is along the bottom, orange are early adolescents, green are middle adolescents, blue is late adolescents, and purple are parents and guardians, which is why there's a wide age span. And what you see is middle and late adolescents scored in the same range as parents and guardians. And most early adolescents scored in that range, but all of the outliers were early adolescence. So this is like really something important for us to consider. So what does this mean for child health research in Nepal? The first is focusing on consent processes. Can we move away from like a legal single decision maker, a consent permission, and think for kids who are a little bit older, thinking about co-consent? This is ethically and conceptually. The other piece is to think about waivers of a consent. A lot of the work being done in Nepal with children are implementation studies or lower risk studies. Is this an area where we can allow the young people to consent for themselves? And finally, all of this points to the need for meaningful engagement of young people in research from when we ask the question to when we present the results. So, thank you.
Almost 2 minutes ahead of your presentation time. So shall we, I just forgot to welcome you because I'm very sorry. So once again, I just correct that, welcome you for this discussion. Every participants are very valuable. So, I mean, after her presentation, do you have any questions, any comments or any reflections, whatever? We can take few. Yeah, please, yeah. Is that okay? Yeah. She has already raised hand, so.
Thank you for the opportunity. I'm Ambika, I'm a student of public health. So when you discussed about capacity of decision making, are there any tools as such that are designed for children, being based on which we can look forward on if our population is in that stage? Because even as adults, we are very new to research. And when we are talking about consenting for an RCT from children, are there any tools as such used in your part of world which we may look through or learn from? Thank you.
So I would be happy to provide tools offline, but I do want to say most of the tools are developed for aging adults and for adults with serious mental illness. so that they tend to overemphasize the cognitive errors that adults make, like memory errors, and don't really address the cognitive errors that a young person might make around sort of risk perception or abstracting to the future. The tool that I use can really only be used in a research setting because it takes like an hour to do. So there aren't quick and dirty tools for young people, but it's something that we really need to think about and something that's specific to the needs of young people and the cognitive processes.
Thank you so much. And basically, I'm thrilled to know somebody is actually presenting the voice of children, because most of the time we think adult can decide for the adolescent.
Yeah.
And if we decide, they have to obey because we are their parents.
Yeah.
And basically, I'm Rila Khanal. I'm public health professional for a long time, and I work for adolescents. And especially recent my experience, we engage lots of adolescents, especially the mental health and children with the NCD and other part of the problem, to co-create solution with them. Initially, as a public health professional, I thought, and they won't speak, they don't have a voice. After I started to work with them, I realized that I was wrong. And they have a problem, they have a solutions.
Yeah.
And having said that, for me, it's a tool. Is they are the one who give us a tool. You know, once you go and have a open discussion with them, creating enabling and non-threatening environment, and use a lots of anthropological and social tool with the consent of the parents, they give a solution as a tool. That's my experience.
Yeah.
I'm happy to talk more.
Yeah, thank you. That's really amazing, and really like engaging adolescents in a meaningful way, building on their capacity.
I think there is not much question. Thank you very much.
Thank you.
This is a very, very, difficult, I think, area regarding ethical, approach for children and adolescents, you know. A lot of studies are not there, actually involving children, and involving their, consent is not possible because they are very small, minor. And for adolescent, of course, he has presented very nice. There is little bit awareness how they can actually provide action, consent somehow. But it is still, we need to have education to realize the questions, you know. If you are conducting a clinical trial, for example, and adolescent can have some voice, but for children, this is again a very, very difficult task. So this type of tools and experiences are very useful to actually onboard those 40%. You mentioned about the products which are being used actually off-label. These are really, really big questions for the medical or pharmaceutical community. So thank you very much for this presentation. So may I ask the further next speaker? I will just invite co-chair Mr. Prajol Jang Pandey to conduct the other part of this. Okay.
Hi everyone, this is again a exciting session for us. Thank you so much, Professor Dr. Mary, for her wonderful presentation. And it's very wonderful and a very important topic regarding child and adolescents and the ethics and research. So next will be from the Western Nepal Hospital, Mr. Lokraj Panta. He holds an MPharm degree and from School of Health and Allied Science, Pokhara University. His topic of presentation will be predictor and drug-related problem in chronic obstructive pulmonary disease patients at a primary hospital at Western Hospital. So let's welcome Mr. Lokraj Panta, and we will be evaluating your presentations. Over to you, Mr. Lal.
Thank you, sir. Namaste and good morning, respected chair and fellow presenters and everyone present in the hall. On the behalf of my research team, I'll be presenting on the predictors and drug-related problem in chronic obstructive pulmonary disease patient at primary hospital in Western Nepal. Now, without any delay, move towards the topic. COPD, all of you are familiar about the term. It means chronic obstructive pulmonary disease, which affects the 5 to 10% of individual over 40, and it was the third leading cause of death in 2019. And management of COPD involves the various medication and drug-related problem. So what is drug-related problem? Drug-related problem is an event or circumstances involving drug therapy that actually or potentially interfere with desired health outcome, which includes medication error and adverse events. And since most of the DRP up to 88% are often preventable if the pharmaceutical care is integrated in the drug therapy, overall health outcome can be optimized. DRP are also prevalent in the primary and both tertiary care setting, affecting the patient families, healthcare providers, and healthcare system globally. However, in Nepal, limited study exists on the DRP in non-communicable disease, especially on the non-focusing study found in the COPD. To bridge this gap, our study aims to assess the prevalence of drug-related problem, explore the associated factors to determine the average prescription cost of COPD patient, compare the prescription cost between COPD patient with DRP and without DRP at a primary hospital in Western Nepal. Talking about the methodology, this study was cross-sectional study conducted between May 2024 to September 2024 among admitted COPD cases at the Elite District Hospital. The sample size was 156 and purpose sampling was stable. Talking about the operational modality, initially the patient or participants are screened as per our inclusion criteria, and the necessary data were taken from the relevant source and data collected and entered. In this process, data collection tool was PCNE version 9.1 classification system were used. Three domain in problem category and 9 domain in cause category were used in this study. Ethical approval was taken from the IRC of Pokhara University, and administrative approval was taken from the Health Service Office, the Elite District Hospital, and following all the ethical consideration. These are the study variables which are included in this study. Then data were entered in the MS Excel, analyzed by using SPSS, and the categorical data were summarized by using frequencies and percentage, while the continuous data were described in the standard deviation and mean. Then the chi-square test was used for bivariate, then followed by bivariate logistic regression analysis was employed to identify the predictors of drug-related problem. And then to gain the deeper insight in the variables, such as age, gender, and comorbidities, we analyze the domain-wise study to identify the specific predictors, excluding those with self-value count below the 5. And independent t-test was assessed to determine the difference between the problem in cause domain with and without DRP. And now moving towards the results. The general characteristics of the patients. The mean age of the participants was 72.2 years, and 54.5% were male, and 41.7% of the participants were illiterate, and 44.9% of the participants were housewife, and 23.7% participants have the non-history of COPD. These are the general characteristics in detail. I'm not going through in detail. Talking about the clinical characteristics of the respondent, 32.7% have no comorbidity, and the mean age of COPD diagnosis is 9 years, and 16.7% have the more than 15 years of duration of COPD diagnosis, and 44.9% have the drug interaction, and the total cost of prescribed drug was 6,543 rupees. Talking about the prevalence of DRP, 71.8% DRP were found, and most common was the treatment effectiveness. Talking about the causes of DRP, out of 344 causes were identified. Among them, C7, which is patient related, was most common, followed by C5, which is dispensing related. And after that, we performed the chi-square test for determining the associated factor. and found that the ethnicity, educational level, comorbidity, severity of disease, drug interaction were significantly associated with DRP. After that, we performed the logistic regression to gain the deeper insight in the variable and found that the male had the higher odds of having DRP related to treatment safety compared to female, and also found that comorbid patient had the higher odds of having DRP related to treatment safety and DRP related to domain others, which is P3. These are the detailed table. I'm not going in detail. Talking about the total prescription cost of drug, in average, the patient invested total of either 6,543 rupees, and also found that, our study found that among the patients who have faced the DRP related to dispensing, the cost increased in average by 525.2 rupees. In this way, our study reveals the high prevalence of DRP among the COPD patient with nearly 3/4 of patients experiencing the DRPs. And this emphasizes the importance of targeted intervention to reduce the DRP among the high-risk groups. And evidence-based prescribing following the guidelines like GOLD and BS criteria are essential to minimize the DRPs. And ensuring the COPD medication availability, training pharmacists on COPD treatment can improve the medication dispensing, which could ultimately reduce the medication cost among the COPD patient. And concludingly, this study highlights the importance of clinical pharmacists in the counseling, personalized education, medication reconciliation, and patient monitoring. And I would like to acknowledge Pokhara University, the district hospital, and all the patients and all helping hands. These are the references. And thank you. If you have any queries, I will be happy to respond. Thank you.
Lokratji, COPD is a very important topic in Nepal because it is been known that is one of the second largest cause of mortality in Nepal. And otherwise, if you can see the data, males are more, prevalence to these COPD cases. And even we compare to the Karnali district, I think Karnali had the most cases of COPD. And the causes are very more smoking, dust, all of the things. And even you have done a very good research on and the drug-related problem in chronic COPD cases. But we would love to hear more about the significant impact that would really cause, no? So result-oriented case studies will be much more better in days to come. Good luck to you, and we can even take 1 or 2 questions from the audience if there is some, and we can discuss on this. Yeah, please go ahead. Anyone who raises it first can ask first.
Okay.
Okay, I have some inquiries here. I noted some. What are the parameters did you consider before starting these studies? Could you please tell me? The parameters means, for example, I could say resource limitation, and then cultural factors, as well as rural versus urban differences, and then I can see the biomass fuel exposure. Did you consider these parameters? I haven't seen this discussion in this theory.
हामीले त्यो कन्सिडर गरेका छौँ सर, सोसियो डेमोग्राफिक क्याटेगोरीमा राखेका छौँ। यसमा मैले टाइम कम भएको हुनाले चाहिँ डिस्कस गरिनँ। त्यसमा अब पास्ट हिस्ट्री अफ COPD के थियो होइन, तपाईँ अर्बन बस्नुहुन्छ कि रुरल बस्नुहुन्छ, अनि त्यसपछि अकुपेसन के हो होइन, त्यो कुराहरू पनि सोधेको थियौँ हामीले।
बायोमास फ्युल एक्सपोजर डिड यु कन्सिडर?
भनेको अकुपेसनमै भनेको त्यो चाहिँ अब ठ्याक्कै सोधेनौँ, अरू कुराहरू चाहिँ कन्सिडर गरेका छौँ।
ओके, थ्याङ्क यू।
यो COPD चाहिँ मेरो एरिया अफ इन्ट्रेस्टमा भएर कोमोर्बिडिटीको स्टेटस इट्स मोर देन 50% एज युभ सेन होइन, 60++ कति थियो। कोमर्बिडिटी र DRP को केही थियो कि अथवा इट वाज जस्ट विथ COPD भन्ने जिज्ञासा।
थियो कोमोर्बिडिटी र सिओपिडीको चाहिँ रिलेसन थियो, जसमा कोमोर्बिडिटी देखेको छ त्यसमा चाहिँ डिआरपीको रेटहरू बढी देखेको थियो, किनभने उनीहरूले चाहिँ मल्टिपल ड्रगहरू युज गरेर हुन्छ। त्यस कारणले अब जस्तै हस्पिटल एडमिट भएको पेसेन्टले अब उसले चाहिँ औषधि जस्तै बिर्सिन सक्छ होइन। अरू डक्टरले त अब सिओपिडी भएर आएको हुन्छ, उसले सिओपिडी मात्रै लेखिदिन सक्छ, उसले चाहिँ आफ्नो खाने टाइम बिर्सेर हुनसक्छ। त्यो कारणले पनि त्यसको चाहिँ सिग्निफिकेन्ट एसोसिएसन देखेको छ डिआरपीसँग। थ्याङ्क यू।
थ्याङ्क यू। सो तपाईँको स्टडीमा 100 भन्दा बढी पपुलेसन हुनुहुन्छ होइन। सो मिन तपाईँले डेटा धेरै ठाउँमा तपाईँले क्यालकुलेट गर्दै गर्दाखेरि, किनकि अब रेस्पिरेटरी डिजिज भनेको हाम्रो देशमा पक्कै पनि अब एउटा सिग्निफिकेन्ट बर्डन छ होइन। सो अब मिन र मिडियन फरक कुरा हो। सो तपाईँको यदि स्ट्याटिस्टिक्स तपाईँले पर्फर्म गर्दाखेरि डेटा नर्मली छ भने त माइट बी तपाईँको त्यो जुन 50 या कतिमा देखाइराख्नु भएको छ तपाईँले हरेक ठाउँमा, त्यसले त्यो माइट बी एक्चुअली द्याट माइट रिफ्लेक्ट द्याट एक्चुअल त्यो एज ग्रुप जसलाई बर्डन भएको हुनसक्ला होइन। तर अब तपाईँले यदि नर्मल डिस्ट्रिब्युसन नगरिकन हाम्रो चाहिँ अब यदि मिनै मात्र पुल गर्नु भएको छ भने सायद त्यो डेटा अलिकति ट्विक हुनसक्ला कि, एउटा मेरो कुरा है। दोस्रो कुरा त्यो तपाईँले धेरै ठाउँमा अब हामी है, अब म अलिकति आफै पनि रिसर्चमा काम गरिरहेको भएर हामी रिसर्चर्सहरूको अलिकति नोभाइस या चाहिँ अलिकति गर्दै गर्दाखेरि रिसर्चर्सहरूको कस्तो प्रब्लम छ भने वी फोकस अन द्याट पी भ्याल्यू है। अब म आफै पनि अब सुरुमा पेपरहरू पब्लिस गर्दाखेरि पी भ्यालुलाई हामी एकदम जोड दिन्थ्यौँ है। सो अब तपाईँको धेरै ठाउँमा त्यहाँ स्लाइड्सहरू आइरहेको छ जहाँनिर पी लेस देन 0.1 राखिराख्नु भएको छ, कहीँ कहीँ पी लेस देन 0.05 पनि छ है। सो 95% कन्फिडेन्स इन्टरभल पनि राखिराख्नु भएको छ तपाईँले त्यहाँ। सो यो अब पी भ्यालु पनि कतिमा चाहिँ सिग्निफिकेन्ट भन्न खोज्नु भएको हो, र त्यो सिग्निफिकेन्ट भ्यालु पनि हाम्रो भ्यालुले ओके 0.05मा सिग्निफिकेन्ट तपाईँको सबै डेटाले देखाइरहेको छ। ओके द्याट्स रियली ग्रेट, द्याट्स रियली ग्रेट। तर त्यो फाइन्डिङ्स चाहिँ हाम्रो अरू नेपालकै अरू कुनै ठाउँमा पनि त्यो कम्पेरेबल छ त? तपाईँको स्टडी त कुरा सिग्निफिकेन्ट देखायो होला होइन, हाम्रो स्टडी सिग्निफिकेन्ट देखायो, तर त्यो अरू ठाउँमा के छ त? हाम्रो नेपाल या अरू नेपालभन्दा बाहिरको आउटस्कर्टमा के छ त है। सो यो कुराहरू पनि यो तपाईँलाई क्वेसन्स भन्दा पनि यो चाहिँ एउटा मेरो चाहिँ एउटा एज अ रिसर्चर यो सबैमा हामीले सोच्नुपर्ने कुरा। पी भ्यालु देखाउँदै गर्दाखेरि त्यो पी भ्यालुलाई नै फलो गरेर ओहो सिग्निफिकेन्ट आयो र यसलाई चाहिँ हामी फलो गर्नुपर्छ भन्ने कुरा हो कि होइन, अथवा जुन चाहिँ तपाईँको एउटा डेटा आइरहेको छ त्यो डेटालाई मात्र पनि हामीले विचार गरेर त्यहाँबाट केही जेनेरेट गर्न सक्छौँ है। र त्यो मिन र मिडियनको कुरा त्यो चाहिँ मेरो लागि सबभन्दा इम्पोर्टेन्ट चासोको विषय चाहिँ त्यो भयो है। 100 जना पपुलेसन हुनुहुन्छ, 100 जना पपुलेसनमा 99 जनाको एज 1 छ, 100th पपुलेसनको एज 100 छ भनेपछि मिन र मिडियन त्यतिखेर हामीले गर्दाखेरि तपाईँको त्यो त धेरै फरक पऱ्यो है। सो तपाईँको यदि कल्मोगोरोव स्मिड नप टेस्ट भन्छौँ हामी है, त्यो स्ट्याटिस्टिकल्ली सिग्निफिकेन्ट छ कि छैन, त्यसको आधारमा चाहिँ मैले तपाईँको त्यो डिजिज बर्डन त्यो पार्टिकुलर पपुलेसनमा सायद त्यतिखेर चाहिँ त्यो मलाई रिलाय हुन्छ। थ्याङ्क यू सो मच।
Actually, not direct. This is question. I'm sorry for sitting. बसेर कुरा गरौँ। Actually, your study is very nice. Congratulations. You have presented like lots of things. तर मेरो थोरै क्वेरी के थियो भनेदेखि we are shifting to towards the non-communicable disease जुन हाम्रो चाहिँ प्रायोरिटी प्रोग्राम छ नेपालमा, र मेजर 4 डिजिजमा चाहिँ हामी हाइलाइट गरेका छौँ है। कार्डियोभास्कुलर डिजिज, आई मिन क्यान्सर, डायबिटिज एन्ड सिओपिडी। तर सिओपिडीको यो रिसर्च भएको थोरै मेरो जिज्ञासा कि गभर्मेन्टले प्रायोरिटीमा चाहिँ सिओपिडी राखे पनि सिओपिडीको कन्ट्रिब्युसन र पेसेन्टको जुन हाम्रो चाहिँ मार्जिनलाइज पिपुल छ त्यसको ट्रिटमेन्टमा चाहिँ आई मिन कस्टको कुरा तपाईँ जुन ल्याउनु भएछ अलिकति त्यसको केही रिकमेन्डेसनमा आयो, कन्क्लुजनमा आएको भए इट वुड ह्याभ बेटर टु इम्प्लिमेन्ट इन द गभर्मेन्ट सेक्टर। केही त्यस्तो छ कि अन्डर लाइक जुन पोभर्टी बिलो पोभर्टी लाइनको जुन सिओपिडी पेसेन्टहरू छ त्यसको चाहिँ एटलिस्ट मन्थली अर इयरली देयर कस्ट अफ ट्रिटमेन्टमा चाहिँ त्यस्तो के कस्तो अथवा प्रिस्क्रिप्सनमा कस्तो खालको छ, रियली दे आर अफोर्डिङ द्याट अर नट? द्याट इज माई क्वेरी। थ्याङ्क यू।
थ्याङ्क यू सर।
ओके, लास्ट क्वेसन छ एउटा मेरो चाहिँ, यो भाइको प्रेजेन्टेसन राम्रो थियो। डिआरपीको जुन
जस्ट नेम पहिला आफ्नो नाम पनि भनिदिनु भयो भने।
सो आई एम प्रोफेसर डक्टर निशा झा एन्ड आई वर्क इन किस मेडिकल कलेज। सो माई स्मल क्वेरी टु यु इज लाइक यु हेभ क्यालकुलेटेड द कस्ट फर द डिआरपिज. So was that cost including all the hospitalized costs also, drug also, and device also, or only the DRPs?
सबैभन्दा पहिले सरले सोध्नुभएको थियो त्यो मिन र उसको कुरा मिडियमको कुरा, त्यसको चाहिँ हाम्रो बेटर आन्सर चाहिँ मेरो माई कलिगले दिनुहुन्छ, हाम्रो प्रकाश सर यतै हुनुहुन्छ, उहाँले दिनु होला। अनि अब म्यामले सोध्नुभएको क्वेसनबाट जाउँ हैन। हामीले चाहिँ कस्ट निकाल्दाखेरि चाहिँ डाइरेक्ट कस्ट मात्र निकालेको, पेसेन्ट हस्पिटलमा आएदेखि जाँदासम्म डिस्चार्ज हुँदासम्मको मेडिकेसन, अब मेडिकल डिभाइसहरू हुनसक्छन्, त्यो सबैको कस्ट उसले हस्पिटलाइज पेसेन्टको मात्रै निकालेको त्यो हो। अनि सरले सोध्नुभएको क्वेसन चाहिँ अब मार्जिनलाइटमा र अब नर्मलमा चाहिँ कति डिफ्रेन्स छ भन्ने कुरो सोध्नुभयो जस्तो लाग्यो मलाई होइन। त्यसमा चाहिँ के छ भन्दाखेरि अब प्राय बिरामीहरू हाम्रो हस्पिटलमा आउने चाहिँ म्याक्सिमम् चाहिँ हेल्थ इन्सुरेन्सको बिरामीहरू हुनुहुन्थ्यो होइन। त्यस कारणले उनीहरूलाई चाहिँ अब जो चाहिँ हेल्थ इन्सुरेन्समा इन्भल्भ भएको छैन ऊ बिरामीलाई चाहिँ अब डिआरपी हुने चान्स अझै बढी देखेको छ, किनभने चाहिँ उनीहरूले चाहिँ अब मेडिसिन किन्न सक्ने एफोर्ड गर्दैनन्। त्यसो हुँदाखेरि चाहिँ उनीहरूले चाहिँ नकिनेर नखाइदिने 2-3 महिनासम्म। मैले अब खानु छ भने चाहिँ आज लैजाने अनि त्यसपछि कहिलेकाहीँ अल्टरनेट डेमा पनि खाइदिने। हजुर
हेल्थ इन्सुरेन्सले चाहिँ सिओपिडीमा चाहिँ जुन गभर्मेन्टले दिने 1 लाखसम्मको जुन छ त्यो चाहिँ सपोर्ट गर्दैन के, द्याट इज द मेन प्रब्लम। त्यसलाई हाइलाइट गरेर गएर एटलिस्ट रिकमेन्डेसन आउँथ्यो होला, जस्तै कि क्यान्सरमा दिन्छ
सरी सर, मैले बुझेअनुसार चाहिँ सर अब हाम्रो चाहिँ के छ भन्दाखेरि हेल्थ इन्सुरेन्सले चाहिँ सिओपिडीमा युज हुने मेडिसिनहरू चाहिँ लगभग कभर गर्छ, त्यो डिभाइस बाहेक। डिभाइस चाहिँ उसले किन्नुपर्ने हुन्छ होइन, अरू चाहिँ मेडिसिन चाहिँ हेल्थ इन्सुरेन्सले चाहिँ कभर गर्छ सर।
Well done, right. Thank you so much for the wonderful presentation. COPD has always been a multi-faceted crisis in Nepal. I'm sabara थाहा भएको कुराहरू हो। त्यसले गर्दा the presenter tried to cover most of the aspect. जस्तै उहाँले prevalence of burden पनि try गर्नु भएको छ cover गर्न, risk factorहरू पनि he tried to cover those risk factor पनि, gender dysphoria कुरा पनि उहाँले cover गर्नु भएको छ. So that is a very good effort. तर जति पनि recommendation आएको छ, we would like to take it in a very good manner and try to incorporate in your research as well. Thank you so much once again for your effort and
मिन र मोडको कुरा चाहिँ हाम्रो प्रकाश सरले चाहिँ अलि स्पष्ट गरिदिनु हुन्छ।
यसपछिकोमा अलिकति कर्नर स्टेसनमा पनि कुराहरू सकिन्छ। हुन्छ, हस्, थ्याङ्क यू सो मच।
Okay, so I mean the next presenter is M. Sundar Sarkar, who is a health system and supply chain expert. She is working almost 25 plus years in this sector. He is a PhD scholar at Noida International University. May I call upon the dais and present his topic, Systematic Review of Evidence-Based Practice of Forecasting and Procurement of Essential Drugs and Medicines, particularly paracetamol and iron tablets in public sector logistics system. So, thank you. Go ahead, sir.
Thank you, Chair. The title is the Systematic Review of the Evidence-Based Practice of Forecasting and Procurement in the Public Sector Health Institution. This is just go. Okay. So the quantification, forecasting, and procurement drugs, the background within the public health system, very critical, as you all know, since we're working on the public health system. And availability, the accessibility of essential medicines are very prominent in the Nepali context. So the evidence-based approach is essential for optimizing this process, particularly low resource settings countries like Nepal, where health system has significant challenges. So objective of this systematic review of literature is to find out the evidences, quantification, forecasting, procurement of essential drugs, but in particular the paracetamol iron tablets of around the, in the globe, so that it helps to do the research on evidence-based practice on quantification, forecasting, and procurement of paracetamol and iron tablets in public health institutions in Nepal. So methodology, the systematic review is conducted to synthesize the extant literature and analyze the content to ascertain the evidence-based practice of quantification and procurement of essential drugs, and the PRISMA flow statement was followed. I'll just go through the, very briefly. So it involves the identification, the screening, eligibility, and included. So among the 680 publications, there were various processes. As you can see, we final record and meeting criteria for the study analysis, the number is 72. So, there's a very good software, the Bosphere, which can synthesize with all these things, and it can with the keywords. It says the bigger the value the things, it has the more sightings around in the keywords in the publication. And this is a bit interesting, and how these the mapping of style reveals the chronological evolution of research themes on the keywords. Like before, this quantitative research was there, if you could, 2018, forecasting was there, procurement, supply chain, but slowly it's moving towards if you see the supply chain management, supply chain, blockchain. Blockchain is now more popular in the supply chain management. That's how, more research is being done in the blockchain and supply chains. So results, evidence-based quantification, forecasting, and procurement of drugs in public health logistics systems are very essential for ensuring availability of essential medicines. Also the quality of essential medicines. I want to focus on the quality also. And the integration of high-quality data system, functioning of logistic management system, LMIs, that you all know in Nepal, is also there. And use of LMIs information is the key. And also effective coordination, collaboration, well-trained health staff, use of modern technology, and optimized procurement process are crucial for enhancing health outcomes, particularly in resource setting, limited settings. And this is very, I want to emphasize in Nepal, it's very, very important. As we went through the federal system, now we have 3 levels of government. So coordination and collaboration is topmost priority. At least in Nepal. And the literature consistently supports the notion that strategic improvements in these areas can lead to significant advancement in public health logistics. So the conclusion is, there is a need to conduct the research on evidence-based practice of forecasting procurement of essential drugs, but paracetamol, iron tablets in public health institutions in Nepal, to achieve the following broad objectives. Establish what methods are currently employed for quantification, forecasting, and procurement in public health institutions. Determine how these methods affect the success and efficiency of procurement, forecasting, and quantification. And determine whether there are any obstacles in a way putting the best supply management techniques into the practice. So that concludes my presentation. Thank you. If you have any questions, I can take your questions.
Thank you, Him, sir. I think this is your topic for a long time. So you are still working on this and doing PhD also.
Thank you.
So I actually wish you best. And as you know that there is the quality of commodities which are required in healthcare settings are in contingent with whatever services we provide from those settings. So if you do not have a good quality logistics in time, if you do not have kind of projection how much will be required, then your procurement and other supply, everything is really in a sample. So we need to really focus on this aspect and do research, definitely. That's a very good point you have highlighted. In this perspective, I think anybody want to add or suggest or have any questions regarding his presentation, please, I would like to welcome. And we are very honored that we have Vice Chair of NHRC here also in this team. So I welcome him also. Okay, please. Anybody? Any? So I think you are ahead of time, so thank you so much. That means you have done good things. Huh? Nobody has questioned you anything. Yeah. Okay. Yeah, one question here, please.
Just the insight, not the question. Thank you, sir. glad to come in, but to give suggestion as well. So basically, using the blockchain, for the blockchain, I think we had kind of test 4 years back for the blood donation system. So basically trying to map out all of the donors using the blockchain. I'm talking specific with Nepal use case only. So there are policy blockade for blockchain, because the thoughts around the blockchain is when there is blockchain or the keyword as a blockchain, the thought process is around the crypto. So that was the blockade. So I would like to discuss more on this. So how we can leverage blockchain for specific for this use case. The reason I'm saying is blockchain aliases to the cryptocurrency, and which is illegal in Nepal. So yeah, thanks.
Sanjay's questions. I think the blockchain, it's now in very developed countries, it's been very much followed, and a lot of literature has been doing in the blockchain. But in the country like Nepal, we're struggling, still struggling with the very basic part of the system, like for example, the LMIS, it's been supported by the donor agencies for a very long time, and now the funding is not there, and that's a very practical problem that we're facing now. That's the one, because to able to do the blockchain, those basic things must run very smoothly. And we have now the 753 level of the palikas, municipalities, where they procure the drugs, and the quality of drugs, the INGs just said, we're struggling on how they procure, what's the quality they are procuring. And this question, like in the insurance part also, there's a very big question on the cost of the medicines. For the one, they are paying 8 rupees, and when they procure, they are procuring for the 2 rupees. So these disparities are there. So I mean, there are a lot of things that we need to. And recently, I just want to inform that we have I was fortunate that we have supported the government of Nepal for the procurement supply chain strategy that's been developed, has been in the process of translation, and if that is approved or endorsed by the government, and I think there are so many things, the price disparities, those part of things can be solved within Nepal. So I think that we should move forward on that part. Thank you for the question.
Yeah, we again have a very interesting presentation from Dr. Ayush Ronia. Ayush Ronia is a MBBS doctor, MD in clinical pharmacology, and a lecturer in Department of Pharmacology at KIST Medical College and Teaching Hospital. His title of presentation would be Treatment Practices, Cost of Treatment, and its Implications in the Management of Hypertension at Sri Birendra Hospitals. Let's welcome Mr. Dr. Ronia.
Thank you, sir. Okay, the topic of my research was treatment practices, cost of treatment, and its implications in the management of hypertension at Sri Birendra Hospital. So hypertension is the most common cardiovascular disease. It is also the principal cause of stroke, myocardial infarction, and sudden cardiac death. Sri Birendra Hospital at Chhaoni has been giving its medical services to the Army veterans, Army staffs, and its families. The treatment is free of cost for the patients of the Army background and to the Army families. The objective was to analyze the prescription pattern and cost of therapy of hypertension at the time of the first day or the initial presentation in patients visiting the OPD and the emergency department of Sri Birendra Hospital. It was a prospective observational study at the medicine OPD and the emergency ward. It was of 6 months duration, and the patients included were newly diagnosed hypertensive patients of all age group without any comorbidities. Exclusion was done to old hypertensive patients with or without comorbidities and to new hypertensive patients with comorbidities. Informed written consent was obtained, and the data was collected on the designed performer sheet. So first, what we did was we took the new hypertensive patients only, and we recorded the data of the BP, the investigations, and the prescription. So the cost of investigations, that is the complete blood count, the renal function test, lipid profile and urine. They have been ordered for all the patients of the hypertension, and the prices of drugs were also obtained from the hospital. Then we categorized the patients according to the Joint National Committee 8, and the type of therapy which we gave, that was monotherapy, polytherapy, or non-pharmacological therapy, was recorded. The cost of drugs was calculated by calculating the unit price of drug times the frequency of the dose, that is once daily, twice daily, or thrice daily for the initial day. And the overall cost of treatment for day 1 was calculated by the cost of drug plus the cost of investigations. Now, these costs, they are absolutely free for the patients of the army background, and the patient do not have to pay anything to the hospital. So a total of 60 patients were included in our study. In these, the pre-hypertension category, there were 10 patients. In stage 1, 27 patients. In stage 2, 17 patients. And in hypertensive crisis, there were 6 patients. There were 57 males, whereas only 3 females were there. In the age group distribution, we saw that the maximum number of patients were from the age group 31 to 35 years, in which 7 were from pre-hypertension stage, 17 from stage 1, and stage 2 there were 7 patients. In the age group 36 to 40, we saw 1 patient who was there in the hypertensive crisis category. In the types of treatment given, for the non-drug treatment, there were 20 patients. In this, maximum number of patients were 12, that is in stage 1. In the monotherapy, there were 22 patients. In this, the maximum number of patients were from stage 1. And in the polytherapy patient, there were 18 patients, in which the hypertensive crisis, there were 6 patients. So the drugs given as monotherapy, amlodipine 5 mg was the most commonly prescribed drug, in which there were 3 patients in the pre-hypertension stage, 7 patients in stage 1, 7 patients in stage 2. Other drugs prescribed were losartan, olmesartan, propranolol, and atorvastatin. In the drugs given as polytherapy, the fixed dose combination of amlodipine and losartan was the most commonest drug prescribed, in which 1 was in pre-hypertension stage, 2 were in stage 1, 5 were in stage 2, and 4 were in hypertensive crisis category. Other combinations were losartan and hydrochlorothiazide, telmisartan hydrochlorothiazide, and amlodipine 10 mg and atorvastatin 40 mg. In the patients who presented in emergency, injectable drugs were given. These patients were first given injectable drugs, and after their BP was stabilized, they were shifted to ward and switched on to oral drugs. So injection furosemide was the most common drug prescribed there to 4 number of patients. Calculating the cost of treatment for day 1 in monotherapy, amlodipine 5 mg was the most inexpensive drug. The per unit cost of this drug was rupees 0.43. The cost of investigations was same for everyone, that is rupees 384.72, and the total cost came to around rupees 385.15. Olmesartan 20 mg was the most expensive drug at rupees 388.01. In the polytherapy category, the fixed dose combination of amlodipine and losartan was the most inexpensive at rupees 385.92, whereas the fixed dose combination of telmisartan and hydrochlorothiazide was the most expensive at rupees 401.72. In the polytherapy category, in the emergency ward, a total of 4 regimens were prescribed. In this, injection labetalol 20 mg IV stat plus tablet amlodipine and losartan fixed dose combination once daily was the most expensive regimen, which cost around rupees 751.92. So concluding, these rates are applicable to Sri Birendra Hospital only, not to the outside market. So olmesartan was 3 times more expensive than losartan. Amlodipine 10 mg was 7 times more expensive than amlodipine 5 mg. Atorvastatin 40 mg was 5 times more expensive than atorvastatin 20 mg. Injection furosemide was 3 times more expensive than injection torsemide. And the fixed dose combination of telmisartan hydrochlorothiazide was 13 times more expensive than fixed dose combination of amlodipine and losartan. So takeaway message is that we saw maximum patients in the age group of 31 to 40, so there is a need to make early lifestyle changes. And from discussion, we found that calcium channel blockers lowers BP more than diuretics, and torsemide is more superior to furosemide, as torsemide has increased bioavailability, longer half-life, beneficial effects on the myocardial fibrosis, the neurohormonal axis, and ventricular structure. Among the angiotensin receptor blockers, olmesartan is the most superior one, whereas telmisartan and losartan show equal efficacy. So I would like to acknowledge Nepal Health Research Council and the 11th National Summit of Health and Population Scientists for giving me this opportunity to present my research. Also, special thanks goes to Sri Birendra Hospital, Chhaoni, Professor Dr. Kumud Kumar Kafle, Associate Professor Dr. Sammud Acharya, Professor Dr. Nisha Jha, and all the faculties of the Department of Pharmacology of KIST Medical College and Nepalese Army Institute of Health Sciences. Thank you.
From questions and feedback from the floor. Use the mic, please. आफ्नो परिचय पनि दिएर गर्दा राम्रो हुन्छ।
नमस्ते सबैजनालाई, मेरो नाम अजय बस्नेत, म नेपाल आर्म पुलिस फोर्स हस्पिटलबाट डिपार्टमेन्ट अफ माइक्रोबायोलोजी। भेरी वन्डरफुल प्रेजेन्टेसन डक्टर है।
थ्याङ्क यू।
सो अब मेरो चाहिँ खासै प्रश्न भन्दा पनि एउटा कुरोको चुरो बुझ्नु भनेर होइन, म माइक्रोबायोलोजिस्ट, मलाई यो नन कम्युनिकेबल डिजिजको बारेमा धेरै आइडिया छैन, तर मेरो आफन्तहरू नेपालको कन्टेक्स्टमा अब आफन्तहरू भन्दै लाँदाखेरि हाइपरटेन्सन भनेको त ग्लोबली नै एउटा मेजर डिजिज हो है। अब मेरो आफन्तहरूमा धेरै हुनुहुन्छ जसलाई चाहिँ हाइपरटेन्सन छ कि, अनि सबैलाई मैले चाहिँ अब थाहा पाएर बुझेअनुसार मेरा नजिकका डाक्टरहरूले मलाई रेकमेन्ड गर्दाखेरि एम्लोइड 5 भनेर युजली इनिसियली दिनुहुन्छ। सो तपाईँको त्यहाँ स्टडीमा खतरा खुतरा गरेर धेरै ड्रग्सहरू युज गर्नुभएको छ। सो कुरोको चुरो
हजुर,
मलाई तपाईँले के भनिदिनु पऱ्यो भने यो रिसर्च त तपाईँले अब हाइपरटेन्सिभै पेसेन्ट मात्र गरिराख्नु भएको छ। सो मैले एम्लोइड 5 भनेर रेकमेन्ड गर्दै गर्दाखेरि तपाईँको स्टडीले चाहिँ के भन्न खोजेको, एम्लोइड भन्दा त्यो जुन अघिको तपाईँले थुप्रो ड्रग्सहरू देखाइराख्नु भएको छ, त्यो एम्लोइड भन्दा पनि त्यो अरू ड्रग्सहरू चाहिँ मोर एप्लिकेबल, मोर राम्रो चाहिँ हो कि, त्यो भन्न खोज्नु भयो?
एक्ज्याक्टली त्यो भन्न खोजेको होइन। जस्तो कि हरेक हस्पिटलको आफ्नो प्रोटोकल हुन्छ होइन, त्यो प्रोटोकल अनुसार चाहिँ सबैले चाहिँ हाम्रो प्रोटोकलमा धेरै जस्तोमा चाहिँ के छ भने स्टार्ट विथ क्याल्सियम च्यानल ब्लकर्स, द्याट इज एम्लोडिपिन, एन्ड स्टार्ट विथ द लोवेस्ट डोज पोसिबल, त्यो हामीले भनेका छौँ। अब यो चाहिँ किनभने डिफ्रेन्ट डक्टर्सले प्रिस्क्राइब गरेको, हामीले खालि त्यो ट्रेन्ड हेरेको, कुन चाहिँ ट्रेन्डमा चाहिँ कुन चाहिँ ड्रग प्रिस्क्राइब मोस्ट भइरहेछ। अनि डिस्कसन्सले हामीलाई के देखायो भने एम्लोडिपिन चाहिँ संसारभरि नै सबभन्दा मोस्ट कमनली प्रिस्क्राइब प्लस द इनिसियल जुन ट्रिटमेन्ट हामीले सुरु गर्छौँ हाइपरटेन्सनको, त्यो चाहिँ म्याक्सिमम डक्टर्सले चाहिँ एम्लोडिपिनबाटै सुरु गर्छ। त्यसबाट कन्ट्रोल भएन भने चाहिँ बल्ल हामी स्विच ओभर गर्छौँ, अथवा केही एडभर्स इफेक्ट देख्यो, पेसेन्टले टलरेट गर्न सकेन भने चाहिँ बल्ल त्यसपछि स्विच अन गर्छौँ।
भन्नु खोजेको कुरा चाहिँ सुरुमा एम्लोइड नै हुन्छ, एम्लोइडबाट त्यसले काम गर्ने भने
हजुर, म्याक्सिमम केसेसमा चाहिँ म्याक्सिमम हस्पिटलमा चाहिँ सुरुवात चाहिँ एम्लोडिपिनले नै गरिरहेको छ, किनभने यो स्टडीले नै ब्याक गरिरहेछ। डिस्कसन त अब मैले यहाँ देखाइनँ, तर मेनी स्टडिजमा चाहिँ एम्लोडिपिनले नै स्टार्ट गरेको देखाएको।
थ्याङ्क यू।
थ्याङ्क यू।
डाक्टर साहबको यो प्रेजेन्टेसनमा देयर इज अ प्राइस डिफरेन्स पनि देखाउनु भएको छ नि।
हजुर सर।
सो वाट डज द्याट टेल यु वान्ट टु टेल इज डज द एक्सपेन्सिभ वान इज बेटर इन क्वालिटी, हाउ डु यु वान्ट टु रिकोरेट टु द प्राइस इन दिज आर 13 टाइम्स एक्सपेन्सिभ देन द्याट, कसरी तपाईँले त्यसलाई उ गर्नुहुन्छ?
थ्याङ्क यू सर। अब सर यहाँ इन्ट्रेस्टिङ फाइन्डिङ के भयो भने, जस्तो कि एम्लोडिपिन, एउटा इक्जाम्पल एम्लोडिपिनको भन्छु, एम्लोडिपिन 5 mg को चाहिँ प्राइस 0.43 थियो, तर त्यही 10 mg को चाहिँ 3.43 छ। जस्तो कि जसलाई 10 mg प्रिस्क्राइब गरेको छ उसलाई त 5 mg ट्वाइस प्रिस्क्राइब गर्दा सस्तो पर्ने भयो नि त, तर प्रिस्क्राइब गरेको 10 mg त धेरै कस्टली भयो। त्यो एउटा की फाइन्डिङ चाहिँ हामीले हस्पिटललाई दियो। अर्को कुरा चाहिँ अब फिक्स डोज कम्बिनेसन जुन टेल्मिसार्टान र हाइड्रोक्लोरोथाइजाइडको थियो, त्यो एकदम कस्टली थियो, अलमोस्ट 7 to 10 टाइम्स नै कस्टली थियो। यो पनि इम्पोर्टेन्ट फाइन्डिङ दियो। अनि जुन रेजिमेन ल्याबिटेलल थियो त्यो चाहिँ 1 पेसेन्टलाई दिएको थियो, त्यो चाहिँ अलमोस्ट 731 छ, जबकि अरू रेजिमेनमा चाहिँ अलमोस्ट 300कै आसपासमा आइरहेछ। सो त्यो की फाइन्डिङ्स हामीले खालि डिफ्रेन्स देखाएको कि यति डिफ्रेन्स आइरहेछ। अब आर्मीले जसरी त्यो मेडिसिनहरू किन्छ, अब त्यसमा के गर्दाखेरि चाहिँ अझै बेटर युजेस अफ रिसोर्सेस हुन्छ भनेर त्यो फाइन्डिङ चाहिँ हामीले देखाएको हो.
Any other?
Namaste. Thank you for the wonderful presentation. मेरो question चाहिँ अब when there is so much of comorbidity ongoing, why was it excluded as part of it? जस्तै जुन कुरोले खर्च बढ्दैछ त्यो कुरोलाई नै किन छोड्नु भयो भन्ने जिज्ञासा.
ओके, थ्याङ्क यू. यसमा चाहिँ के भयो भने अब कोमोर्बिडिटिजको जुन पेसेन्ट्सहरू थियो उहाँहरूलाई चाहिँ अब फलोअप गर्नेदेखि लिएर त्यसको चाहिँ हामीलाई अलिकति गाह्रो भएर चाहिँ यो न्यू हाइपरटेन्सिभ पेसेन्ट्सलाई चाहिँ कलेक्ट गर्न सजिलो, यो डेटा कलेक्ट गर्न सजिलो भएर चाहिँ हामीले त्यो आधारमा मात्रै छुट्याएको. ओल्ड पेसेन्टलाई गर्दाखेरि कोमोर्बिडिटिजको अलिक गाह्रो पनि भयो. त्यो माथि धेरै पेसेन्ट चाहिँ काठमाडौँमा खालि मेडिसिन लिन आउनुहुन्थ्यो कि बाहिर काठमाडौँ बाहिर बस्नुहुन्थ्यो अनि फलोअप गर्न गाह्रो हुन्छ भनेर चाहिँ उहाँलाई इन्क्लुड नगरे हो.
To be clear about, it's really good study. I think we need further more study on this type, regarding pharmacoeconomics, if you are talking about cost of treatment and quality of treatment. So there is one issue I think I have seen. For example, in case of amlodipine, cost you are mentioning like 1.43 or something amount, and there is 300 plus of diagnosis. Diagnosis cost is treatment cost. Other costs are once, but the medicine goes on for a long time. So it is not covered that. One day cost is less for a medicine.
Yes, sir.
But if you look into the longer period of time, the medicine cost go on increasing. So I think we have to correlate that way also. And then we can come up with some idea that the treatment cost is different in different treatment scenario. So thank you very much for highlighting this very interesting and very important topic of pharmacoeconomics. So we want to explore this further in other areas also. Maybe in the previous section we talked about COPD, which is also highly increasing trend, and hypertension is always there. Thank you very much. That's just to add that. Yeah.
Thank you, sir.
Thank you. Well covered, and I would strongly recommend to be more precise on this research, because we try to cover cost, practices, cost of treatment, and implication in management. So my personal request would be try to be more precise in particular section of research. That will give you a more impactful ways of deciding things in later on futures. So very good presentations, and pharmacoeconomics is the very core interest of all of ours. Thank you so much, and hand over to Narayan sir.
I think this is the last presentation, final presentation for today, I hope. Rohit Agrawal is going to present next topic regarding unlocking insights into medication utilization patterns in Nepalese healthcare, a meta-analysis and systematic review using WHO prescribing indicators. So Rohit Agrawal is a final semester MPharm clinical pharmacy student with a BPharm degree, interested in clinical research and patient-centered pharmaceutical care. In which university you are?
Purvanchal University.
Purvanchal University, okay. So welcome to you, and then floor is yours, yeah. Go ahead.
Thank you, Chair. Respected Chair and delegates, I, Rohit Agrawal, I am going to present on the study Unlocking Insights into Medication Utilization Patterns in Nepalese Healthcare, meta-analysis and systematic review using WHO prescribing indicators. This is a result of group effort of mentioned individuals. Irrational drug use is a globally prevalent issue which results in negative consequences, negative health impacts, and economic impacts. Such issues are even worse in low-resource settings like in Nepal. One approach to achieving rational drug use is through drug utilization studies. WHO prescribing indicators were developed for the same objective. These are highly standardized objective tools that helps to evaluate the rationality and quality of prescriptions and also to identify the drug use problems. The WHO core prescribing indicators includes the mentioned 5 indicators. In case of Nepal, drug utilization studies have been very limited in context of WHO prescribing indicators, and the studies reporting these indicators have shown variable patterns of drug utilization, and no quantity synthesis has yet been done to provide the drug utilization pattern in Nepal. So this study aimed to quantitatively summarize the published studies assessing the drug utilization across various healthcare settings in Nepal using at least one WHO core prescribing indicators. For this aim, we assessed various databases to identify the studies that assessed the drug utilization in healthcare facilities of Nepal and reported at least one of the WHO prescribing indicators. Studies not specifying total number of patient encounters and studies using only number of prescriptions were excluded in our review. After the identification of the studies, relevant data were extracted, which includes study characteristics, methods, and the outcomes, and the studies were critically appraised using a 14-point scoring system and classified as high, moderate, or low quality studies. For data analysis, the unit of analysis was study settings and data point were extracted from the studies. The outcome variables were average number of drugs per encounter, percentage of drugs prescribed by generic NING, percentage of encounters with antibiotics prescribed with injection prescribed, percentage of drugs from WHO essential medicine list and from Nepal essential medicine list. For outcome 1, that is average number of drugs, median and 95% confidence interval was used for quantitative synthesis. For the remaining outcomes, for remaining indicators, proportional meta-analysis was done using random effect model. Sub-analysis was also done, and a subset meta-analysis was also done, excluding the studies that did not that targeted on specific drug or disease groups. Moving on to the results, this review initially identified over 10,000 studies. Through a series of screening, only 88 studies were included in the final review. Out of these 88 studies, the earliest studies was from 1989. Over the period, the studies on drug utilization has shows fluctuating publication activity with an average of 3.7 studies per year. Towards the 2020s, however, the publication activity has gradually increased. In total, the 88 studies included 2,108 healthcare facilities, of which 1955 healthcare facilities were studied by 2 national surveys. Out of the remaining 153 healthcare facilities, most were public and most were hospitals. Critical appraisal shows that most of the studies included in the study were of moderate quality. The major non-compliance criteria were inadequate sample size and inadequacy to describe how medicines were counted and how were regarded as antibiotics or injections. For quantitative synthesis, 283 separate data points were extracted from the 88 studies, which assessed over 60,000 patient encounters, most of which were for average number of drugs per encounter. From quantitative synthesis, we found that the overall 2.8 drugs per encounter were prescribed in Nepalese healthcare facilities, which was well above the WHO recommendation of 2 drugs per encounter. Scenario was similar to in all healthcare facilities. However, primary healthcare facilities showed a better result with 1.8 drugs per encounter. For remaining indicators, proportional meta-analysis showed that none of the indicators were optimum as per WHO recommendation. Generic prescribing was only 1/4 of the recommendation. Drugs from essential medicine list were only half, and antibiotics prescription were almost double to the recommendation. Even if the studies that specially focused on specific drugs or disease group were removed, the encounters with antibiotics remained 1.5 times the recommendation from WHO. If you look at the trend of these indicators, generic prescribing seems to be declining towards the 2020s, while drugs from the essential medicine list to be also declining. Encounters with antibiotics, although seems to be flat, the recent change in burden of disease from communicable to non-communicable disease indicates that flat encounters with antibiotics is actually overuse of antibiotics over time. If we look at this difference in these indicators across the different level of healthcare facilities, primary healthcare facilities showed better prescribing indicators as compared to tertiary healthcare facilities. However, when we did a subset meta-analysis, we found that prescriptions with encounters with antibiotics were actually lower in tertiary as compared to primary healthcare facilities, because most of these tertiary care hospitals were included in the antibiotic specific studies. Similar cases were seen when subgroup analysis was done using healthcare facility administrations. The public healthcare facilities showed better results than the private healthcare facilities in indicators. However, the public healthcare facilities showed encounters with antibiotics higher than the private. Subset meta-analysis indicates that this difference was much higher, 1.5 times higher in public, and subset meta-analysis also showed that generic prescribing was 2 times higher in public healthcare facilities than the private healthcare facilities. So from these results, we identified that irrational prescribing practices across the healthcare facilities in Nepal based upon the WHO co-prescribing indicators. There were overuse of antibiotics, under prescription of drugs from essential medicine list, and minimal generic prescribing. This leads to increased risk of antimicrobial resistance and also leads to less affordability and accessibility of drugs to the individuals or patients. Based upon this, we recommended targeted interventions based on different healthcare facilities, educational programs on prescribers, and continuous drug utilization review and monitoring to identify more drug use problems, to monitor the conditions, and to evaluate whether these programs are being effective or not. This is all. Thank you.
I think the presentation is, so far I think that was expected one. I was also I'm currently leading a team for generic prescribing in Nepal. So it will be very useful for me also. Before taking, I think, your review, let's have few questions, few queries or suggestions, anything. One raised hand there. So please.
I'm audible? Yes. So I'm Dr. Sri Krishna Shrestha. I'm a clinical dermatologist, and I'm also a chair of Institutional Review Committee at Shir Memorial Adventist Hospital, Banepa. My question is, are generic drugs available in Nepal? Because even Royal Drugs have, like paracetamol, and it's under the trade name Cetamol. So it's a trade name. So are generic drugs available? Effective implementation of generic medications need generic name, like you can't, sell paracetamol as Cetamol. It's a trade name.
Is this the question for me or?
All for, like pharmacologists and of course the...
I think we misunderstood the very basic of generic. Generic, you are right, there are not in generic name as such. These generic medicines have been given a brand name. So we are confused about this kind of concept. I think this is very understandable. But 99% of the products in Nepal are generic, because they have been given generic, what you call brand names, because the manufacturers wants to give their name separately. So these are manufacturer-led names. However, they are not actually, they are also generic. So we should not be confused about this very basic of that. Definitely what he is trying to present is government of Nepal also procure those branded generic, but in the name of generics. So this policy has been implemented for several years. So I think that will be just a, reflection for you. But definitely there are concepts that you just put only generic name and then put into the market. For that also there are generic products in the market. So you can just name for a few. For example, ringolactate. Ringolactate is available, and DNS is available. They are generic already. So there are several, if you say in that term also, but not in, there are also some of the manufacturers started to give them the brand name also. So we are discussing on that. Definitely your, reflections is right, because we can just provide only generic name also. So that depends because the government can decide that we can allow those licensing also. There is no any obstruction for this. But because it is a private-led, market, because it is manufacturer-led market, so they want to promote their products on their own name. That's why they have been given a branded generic form. So that is just a clarification. But maybe I just, yeah, please.
Thank you for the sharing the study. मेरो जिज्ञासा मात्रै मैले नबुझा पनि हुनसक्छु होइन तपाईँको प्रेजेन्टेसनमा मैले बुझ्न सके अनुसार डिजिज कन्डिसन अथवा स्पेसिफिक कन्डिसनलाई कन्सिडर गरिएन भने जस्तै बुझा इफ आई एम रङ प्लिज करेक्ट मी एन्ड त्यसपछि हामीले लगेर हेल्थ फेसिलिटीमा प्रत्येक इन्काउन्टरमा दुईवटाभन्दा बढी ड्रग प्रिस्क्राइब गऱ्यौँ भने द्याट्स रङ वी आर डुइङ भन्ने कुरालाई हाउ आर वी मेकिङ इट मोर जेनरलाइजेबल बिकज अहिले अहिलेदेखि हामीले सुनिरहेछौँ एनसिडिज भनिरहेछौँ मल्टिमर्बिडिटी भनिरहेछौँ एउटै रोगको 3-4वटा औषधि खानुपर्ने बिरामी सायद आजको दिनमा प्रत्येक घरमा हुनुहुन्छ होइन त्यसलाई कसरी चाहिँ स्टडीले एड्रेस गरेको छ भन्ने जिज्ञासा
थ्याङ्क यू पहिला चाहिँ त्यो स्पेसिफिक डिजिज वा ड्रगलाई चाहिँ सबसेट मेटाएनालाइसिसमा मात्रै रिमुभ गरिएको हो किनकि त्यसले गर्दाखेरि चाहिँ अरू प्रिस्क्राइबिङ इन्डिकेटर्सको भ्यालुलाई असर पारिएको देखियो कुनै केसमा मोस्टली चाहिँ एन्टिबायोटिक्स इन्काउन्टरमा त्यो केसमा मात्रै त्यसलाई एलिमिनेट गरेको एभरेज ड्रग्स पर इन्काउन्टरमा एलिमिनेट गरिएको छैन दोस्रो कुरो चाहिँ जुन डब्ल्युएचओले रिकमेन्डेसन दिएको छ 2 भ्यालु भनेर त्यो चाहिँ एउटा अप्टिमम रिकमेन्डेसन मात्रै हो कि ओभरअलमा चाहिँ तपाईँको हरेक डिजिज कन्डिसन्स हरेक एज ग्रुप लिएर हेर्दाखेरि चाहिँ 2 चाहिँ अप्टिमम मार्क हो भनेर त्योभन्दा बढी हुनु रङ चाहिँ होइन तर 2 चाहिँ एउटा अप्टिमम लेभलमा एउटा नेसनल लेभलमा हेर्दाखेरि चाहिँ 2 चाहिँ एउटा अप्टिमम मार्क हुन्छ 2.8 ले चाहिँ ओभरअल अलिकता पोलिफार्मेसीतिर गइरहेको छ कि भनेर इन्डिकेट गर्छ त्यो राइट या रङ भन्दा पनि चाहिँ त्यसमा चाहिँ केही इफेक्ट देखाउनुपर्छ अथवा त्यसको केही अरू केही कारणहरू छ कि भनेर अरू अध्ययन गर्नुपर्छ भनेर चाहिँ इन्डिकेट गर्छ
डाक्टर साहब हजुरको रिसर्च एकदमै राम्रो है सो मेरो अगाडि पनि हाम्रो एउटा सिस्टमेटिक रिभ्यू गर्नुभयो डाक्टर साहबले है सो मेरो एउटा क्युरी चाहिँ अब एज अ माइक्रोबायोलोजिस्ट हाम्रो माइक्रोबायोलोजीको पेपरहरू चाहिँ सिस्टमेटिक रिभ्यू एन्ड मेटा एनालाइसिस गर्दाखेरि प्रोस्पेरोमा रजिस्टर गर्नुपर्ने हुन्छ यहाँहरूको स्टडी चाहिँ प्रोस्पेरोमा रजिस्टर गर्नुपर्ने हो कि गर्नुभएको छ हजुरको स्टडी
गरिएको छ त्यो सायद त्यहाँ छुटेको छ प्रोस्पेरोमा रेजिस्टर्ड छ यो स्टडी
सो मेरो अर्को एउटा प्रश्न त्यहाँ हजुरको टोटल लिटरेचर 10,000 हाराहारीमा छ होइन सो 10,000बाट हजुरले आफ्नो फाइनल त कति अब 50, 30, 60 कतिवटा लिटरेचरमा यु ह्याड पुल द्याट है सो हाउ मच टाइम यु ह्याड एलोकेटेड टु स्क्विज फ्रम द्याट 10,000 टु त्यति थोरै लिटरेचरमा कति जति समय लागेर कसरी गर्नुभयो तपाईँले त्यसलाई कसरी चाहिँ पुल गर्नुभयो
हामीले चाहिँ एउटा अनलाइन प्लेटफर्म छ कोभिडेन्स भनेर त्यो युज गरेर चाहिँ हामीले स्क्रिनिङ गरेको छौँ त्यसमा एब्स्ट्र्याक्टदेखि फुल टेक्स्ट स्क्रिनिङ गर्नमा हामीलाई टोटल 3 मन्थ्स लागेको थियो त्यसमा चाहिँ हामीले 2जना रिभ्युअर्सहरू छौँ 2जना रिभ्युअर्सहरूले चाहिँ इन्डिभिजुअली एसेस गरेर कुनै पनि किसिमको कन्फ्लिक्ट आएमा चाहिँ एउटा थर्ड रिभ्युअरले चाहिँ फाइनल डिसिजन दिएर हामी चाहिँ 88 स्टडिजमा पुगेका थियौँ
ओके थ्याङ्क यू अनि अर्को एउटा कुरा नि जस्तै डाक्टर साहबले के भन्नुभयो भने प्राइमरी हेल्थ केयरमा एउटा कुनै इन्स्टेन्स थियो त्यहाँ जहाँनिर तपाईँले के भन्नुभयो भने प्राइमरी हेल्थ केयरमा टर्सरी हेल्थ केयरमा भन्दा बेटर र कम चाहिँ एन्टामाइक्रोबियल मिसयुज भएको छ भन्ने कुरा गर्नुभयो मेरो क्युरी टर्सरी केयर सेटिङमा स्पेसियालिस्ट डक्टर्सहरू मोर एक्सपर्ट मोर बेटर प्राइमरीमा नहुने भन्न खोजेको होइन तर द फ्रिक्वेन्सी होइन पक्कै पनि टर्सरी केयर सेटिङमा बढी हुनुहुन्छ सो त्यो हुँदै गर्दाखेरि वाट कुड बी द रिजन त्यो प्राइमरी हेल्थ केयर सेटिङमा चाहिँ टर्सरी सेटिङमा भन्दा बेटर एन्टा ड्रग्सहरू युज गर्नुको कारण चाहिँ के हुनसक्ला
हजुरले सायद अलिक बुझ्न मिस्टेक भयो होला प्राइमरीमा चाहिँ एन्टिबायोटिक इन्काउन्टर्स चाहिँ बेटर छ कम छ टर्सरी भन्दा अरू एन्टिबायोटिक प्राइमरीमा चाहिँ एन्टिबायोटिक इन्काउन्टर्सहरू बढी छ अरू इन्डिकेटर जेनरल प्रिस्क्राइबिङदेखि लिएर इसेन्सियल मेडिसिन लिस्टहरू चाहिँ बेटर छ तर एन्टिबायोटिक प्रिस्क्राइप्सन चाहिँ प्राइमरी लेभलमै बढी छ टर्सरी लेभलमा कम छ हजुरले भने जस्तै टर्सरी लेभलमा अलिकता मोर स्पेसिफिक ट्रिटमेन्ट भएको कारणले गर्दाखेरि नै त्यो एन्टिबायोटिक ट्रिटमेन्ट्सहरू चाहिँ कम देखेको हुनसक्छ
ओके अनि लास्टमा हाम्रो एउटा स्लाइड पनि आयो जहाँनिर चाहिँ अब ड्रग रेजिस्टेन्स होइन अब एज अ माइक्रोबायोलोजिस्ट अब मेरो चाहिँ हाम्रो माइक्रोबायोलोजीको कुरा चाहिँ जहिले पनि एएमआर भन्छौँ हामी एन्टामाइक्रोबियल रेजिस्टेन्सको कुरा गर्छौँ है सो कुरो चाहिँ त्यहीँ नै आउँछ कि हाम्रो सो यो अब मोर देन क्वेसन भन्दा पनि यस अब 2050मा डब्लुएचओले अब लगभग एएमआर अहिलेसम्मको पेन्डेमिक त केही नै होइन यो पेन्डेमिक जहाँनिर त अहिलेसम्म हामीसँग धेरै कुराहरू थियो वी क्यान फाइट द्याट अगेन्स्ट द्याट पार्टिकुलर प्याथोजेन होइन अब कोभिडको लागि पनि त अब वी कल द्याट सो अब भ्याक्सिनको कुरा गऱ्यो होला के होइन अब त्यो डेक्जामेथाजोनको कुराहरू आयो होला अब 2050मा त डब्लुएचओले प्रेडिक्ट नै गरिसकेको छ जहाँनिर चाहिँ एएमआर पेन्डेमिक हुन्छ त्यो AMR पेन्डेमिक यस्तो पेन्डेमिक हुन्छ जहाँनिर वी सिम्पली वेट वाच सी पिपल डाइङ है. सो अब यो कुरा चाहिँ अब प्रायोरिटी प्यासेजेसको कुराहरू उठाइरहेको छ होइन WHO ले. सो तपाईँको स्टडी अघि हाम्रो एकजना म्याडमले सोध्दै हुन्थ्यो कहाँनिर चाहिँ गरेर कोरिलेट गर्न सक्छौँ. यस द्याट कुड बी एन्डर पार्ट जहाँनिर चाहिँ अब अपकमिङ पेन्डेमिक नै हाम्रो अब WHO ले फोरकास्ट गर्दै गर्दाखेरि यो स्टडीले कता कता त्यो AMR को पेन्डेमिकसँग गएर चाहिँ के त तपाईँको युनाइट गर्न सक्छ है. सो थ्याङ्क यू भेरी मच.
Thank you. To add on more on this, and could be your findings matching. There could be some of the recommendation for improvement could be on your paper could be like training and guidelines should be there. किन भन्दाखेरि यो workshop on WHO standard practice and यो protocol practice को लागि अलिकति हामीले ट्रेनिङ गर्न सक्यो भने चाहिँ राम्रो पनि हुन्छ हैन. एउटा कुरा त्यो. अर्को भनेको पोलिसी इन्फोर्समेन्ट कुराहरू नै हो. हामीसँग पोलिसीहरू इन प्लेस छन् तर त्यसलाई अलिकति हामीले इन्फोर्स गर्न सक्ने हो भने त्यसले एउटा राम्रो उपरि ल्याउँछ र AML को एडेरेन्सलाई पनि त्यसले इन्स्योर गर्न सक्छ जस्तो लाग्छ. अर्को भनेको AMR को कुराहरू हामीले धेरै अगाडिदेखि नै कुरा गरेका छौँ. अहिले अलिकति इमर्जिङ पनि छ, मिसयुज पनि भएको छ र त्यसले गर्दा एन्टी माइक्रोबायल स्टुवर्ड प्रोग्रामहरू पनि हामीले सुरु गर्न खोजेका छौँ. अर्को कुरा त्यो. फोर्थ कुरा चाहिँ डिजिटल टुलहरूलाई पनि हामीले युज गऱ्यो भने चाहिँ यी प्रिस्क्रिप्सनको प्र्याक्टिसहरूलाई पनि अलिकति एडभान्स पनि ल्याउन सक्यो भने त्यसले धेरै हदसम्म हामीलाई इट विल रियली हेल्प अस होइन. तर हाम्रो जस्तो देशमा द कन्ट्रिज लाइक आवर्स वेयर WHO प्रिस्क्राइबिङ इन्डिकेटर्स चाहिँ क्रिटिकल छ टु एड्रेस. किन भन्दाखेरि हामीसँग चाहिँ इरेसनल ड्रग युजहरू बढी छ. किन भन्दाखेरि हामीसँग जस्तो देशमा लो इन्कम सेटिङ भएको ठाउँमा चाहिँ यो कुराहरू अझ बढी च्यालेन्ज जस्तो लाग्छ. त्यसले गर्दा राम्रो इफोर्ट हो जति पनि उहाँले गर्नुभएको छ. अर्को कुरा भनेको अब स्ट्रेन्थनिङ पोलिसी एउटा कुरा, डेफिनेटली प्रिस्क्राइबिङ प्रोसेसलाई अलिकति बढाउने. अर्को भनेको ट्रेनिङ र डिजिटल इन्फ्रास्ट्रक्चरलाई डेभलप गर्ने हो भने चाहिँ ओभरअल रूपमा हामीले त्यो यो जुन ग्लोबल एडभान्समेन्टको जुन ग्यापहरू छ त्यसलाई चाहिँ हामीले फुलफिल गर्न सक्छ लाग्छ. भेरी गुड स्टार्ट. आई थिङ्क वी सुड बी कमेन्डेबल वर्क गर्नुभएको छ उहाँले. म अलिकति इन्पोर्ट गर्नु राम्रो हुन्छ. आई डोन्ट थिङ्क.
Thank you. I think this study, I was not imagining like students are doing such a good work. It's really good.
Thank you, sir.
So we are also expecting a few more to come like this. So this will definitely put us in a right place and we can go through evidence-based kind of thing. But the previous presentation, he said that there is a different kind of protocol used by different hospitals. I think that should not be like that. I think for hypertensive treatment, for example, there are, understandably, most of the clinicians are using similar protocol, I think. And every hospital do not have their own kind of protocol in every case. That may be patient specific, of course, but protocols are always in a similar kind of principle. So definitely in your case also, like there is more than 3 prescriptions. That may be because there are comorbidities and other issues that may definitely are required. That's not a, irrational use of medicines. However, if you look into the, previous studies of Nepal also, we have almost 3 on an average, so which is aligning with your study also, almost, So it looks like meeting to the previous, our experience. We need to really improve. We need to improve the practices through several interventions, working together, and studies like you to actually uncover situations, what we are actually following in different settings. So different kind of study in other hospitals also will add up into this. Yeah. Thank you very much for this very interesting study. And with this, I think we have almost come to the end of this.
Thank you.
Discussions. Yeah. Thank you. I think I will hand over this mic to.
Thank you, sir. Now we reach to the end of this insightful and thought-provoking session on essential medicine and pharmaceutical products. I would like to take a moment to sincerely thank all our distinguished presenters for their valuable contributions, our esteemed session chairs for guiding this discussion so smoothly and meaningfully, and all the participants present here. Before we officially close the session, I would like to request our session chairs to present a token of love and appreciation to our presenters as a gesture of gratitude for their time, effort, and expertise. As I call the name of the presenters, please be in the stage to receive the token of love. I'd like to start with Professor Dr. Mary Oates. Next, Mr. Lok Raj Panta. Mr. Hem Sundar Sakya. Dr. Ayush Rauniar. And Mr. Rohit Agrawal. Now, I would like to request Professor Dr. Ajit Raemaji, Vice Chairperson of Nepal Health Research Council, to provide a token of love to our session chairs as a gesture of gratitude for their valued time, effort, and exceptional leadership throughout the session. Now, I would like to invite our presenters to be in the stage to have a photo with the session chairs. Before we part our ways, I am pleased to announce that we will have an oration and award distribution ceremony after a short tea break. Please join us in the main hall. Thank you so much.
In my naivety, and I fell on the honey trap.